Assalamu alaikum. I'm Professor Dr. Hayder Mubarak. This is a lecture on the anatomy of the spinal cord as part of the curriculum in neuroanatomy. As you can see in the figure, the spinal cord runs inside the vertebral canal. It continues above with the medulla oblongata above the level of the first cervical vertebra, and below it ends at the level of L1 vertebra. The lower end of the spinal cord, as the figure shows, is conical in shape. It is pointed or conical in shape. This lower end of the spinal cord is called conus medullaris. Below the conus medullaris, the vertebral canal does not contain spinal cord below the level of L1 vertebra, below the level of the lower border of L1 vertebra, as you can see in the figure. The vertebral canal does not contain any tissue of the spinal cord, but instead of that, the pia mater covering the spinal cord will extend below L1 vertebra as a thread-like structure which is called phylum terminalis, which is written here as terminal phylum or phylum terminalis. And surrounding this thread-like extension of the pia are the spinal nerves of the lower segments of the spinal cord, forming horse tail-like configuration which is called coda equina. If we have a section, a transverse section into the spinal cord, we will see that the tissue of the sectioned spinal cord shows H-shaped gray matter. This H-shaped gray matter is formed mostly of neurons, of nerve cells, and neuroglia. And this H-shaped gray matter is formed of right and left ventral horns. These ventral horns are containing motor nerve cells or motor neurons. And also the H-shaped gray matter shows right and left sensory horn or dorsal horns, because here the neurons are mostly concerned with sensation. The ventral motor or anterior motor horn and the dorsal or posterior sensory horn or column are connected by a middle tissue of gray matter, which is called the gray commissure. This gray commissure contains a canal which is called central canal of spinal cord that is containing cerebrospinal fluid, which is the CSF denoted here. Around this H-shaped gray matter of the seen in transverse section of the spinal cord, you can see the white matter of the spinal cord. And the white matter of the spinal cord is called like that because it contains myelinated nerves. And you know the myelin around surrounds the nerve fibers. And the myelin is a lipid, and that's why it is designated as a white matter, because it appears some way white in color due to the myelin, to the lipid of the myelin around the nerve fibers in this region around the H-shaped gray matter. The white matter is divided into right and left half. posteriorly by posterior median septum, which is extension from the pia mater adherent to the surface of the spinal cord. So you can see that the surface of the spinal cord contains the pia mater that extends deep into the white matter posteriorly, forming the posterior median septum, and this posterior median septum divides the white matter posteriorly into right and left, while anteriorly the white matter shows a deep anterior median fissure that extends so deep to divide the white matter also into right and left half, but this fissure will not extend to the gray commissure. Always there is a region of white matter between the anterior median fissure and the gray commissure. This region of the white matter is called the white commissure, or the commissure of the white matter. If we involve the posterior median septum and the anterior median fissure in classification of the white matter of the spinal cord, in addition with the H-shaped gray matter, you can divide, or we can divide, the white matter into funiculi or columns, in which we may call this region between the anterior median fissure and the ventral or anterior horn of gray matter. This region could be called as the anterior white column, and this region between the posterior median septum and the posterior column or dorsal horn, this region could be called as the posterior white column or funiculus, while that region which is in between the lateral aspect of the spinal cord laterally and the dorsal and ventral horn medially, this region could be termed as the lateral white funiculus or lateral white column. At each segment of the spinal cord, for example, cervical segment, thoracic segment, lumbar segment, or sacral segment, you know, we have 12 thoracic, 8 cervical, and so on. At each of these segments, we have many rootlets of spinal nerve originating from a region on the lateral side of the spinal cord. So these rootlets could be seen originating from the sides of the spinal cord, ventrally and dorsally. The rootlets ventrally unite to form the ventral root of a spinal nerve, while the rootlets dorsally or posteriorly unites to form the dorsal root of a spinal cord. And the region to which the rootlets are concerned, or from which the rootlets are originating, this region is called a segment of the spinal cord. The roots, the ventral root and the dorsal root, of course, carries the functions of the spinal cord from which they are originating. The ventral root is motor in function, while the dorsal root is sensory in function. Both the ventral root and the dorsal root unite to form the spinal nerve, and you can see that the union of the ventral motor root and the dorsal sensory root occurs at the level of the intervertebral foramina, and so we can see that the spinal nerve projects out of the intervertebral foramina, and we can see that the dorsal root shows a dilatation before the intervertebral foramen. That's mean before union of the roots, dorsal and ventral roots, to form the spinal nerve. This dilatation in the dorsal root before union with the ventral root is called dorsal root ganglia, and actually this dilatation contains nerve cells, neurons, which are sensory neurons, and We will talk about this later on. When the spinal nerve exits out of the intervertebral foramina, you can see that the spinal nerve by that time is mixed nerve because it contains fibers from the ventral root, which is motor, and fibers from the dorsal root, which is sensory. So the spinal nerve is a mixed motor and sensory nerve. After being exit from the intervertebral foramen, the figure shows that the spinal nerve will soon divide into a ventral ramus and a dorsal ramus. And again, each of the ventral and dorsal rami are mixed nerves, sensory and motor nerves. The dorsal ramus of a spinal nerve passes backward, and it will supply the skin on the sides of the midline of the back only, and also supply the muscles on the sides of the midline also only, and this supply will be segmentally. And you know, the muscle on the sides of the midline posteriorly is the erector spinae muscles. And when we say that this dorsal ramus supply the erector spinae muscle posteriorly on the side of the midline and supply the skin posteriorly on the side of the midline segmentally, which means that each segment will supply a piece of muscle and a piece of nerve adjacent to it only. It will not have a wide distribution. The dorsal ramus will supply the nerve, the muscle, and the skin just adjacent to it, while the ventral rami will be passing to a long distance, supplying many regions and in the trunk and the limbs. So if you want to say that you have segments of the spinal cord, you have to consider how many regions in the spinal cord that each of them having rootlets originating from it. And accordingly, as everybody know, we have 8 cervical segments in the spinal cord, 12 thoracic segments, 5 lumbar segments, 5 sacral segments, and 1 coccygeal segment. An exception to the rule of rootlets, rule of ventral rootlets and dorsal rootlets originating from the sides of the spinal cord. This exception is seen in the cervical segments of the spinal cord from C1, which is the first cervical, to C4, which is the fourth cervical. Here, you have ventral rootlets forming ventral root and dorsal rootlets forming the dorsal root. But in addition to these, segments from C1 to C4 of the spinal cord shows a mid-lateral rootlets. These mid-lateral rootlets from C1 to C4 will unite with each other and ascends upward, and thus forming a single trunk of nerve by union of these rootlets originating from the mid-lateral side of the cervical segments from C1 to C4, in addition to the dorsal and ventral rootlets. This single trunk formed by these rootlets is called the spinal accessory nerve. That nerve, the spinal accessory nerve, enters into the skull via a foramen on the inferior aspect of the skull, which is called foramen magnum, and running for a short distance inside the cranial cavity, inside the skull, and then exit out from the jugular foramen of the skull to form the accessory nerve. And this spinal accessory nerve at this region unites with the cranial accessory, and thus both form the 11th cranial nerve, which is the accessory nerve as it is shown here. The spinal accessory nerve supply sternomastoid muscle of the neck and the trapezius muscle on the back of the shoulder region, on the scapular region, and you know trapezius from your anatomy of the upper limb. Sternomastoid will be studied with the anatomy of the head and neck. Again, this is a figure showing the rootlets originating from C1 to C4 segments of the spinal cord in the midline laterally. Of course, these rootlets are originating from these segments, the cervical segment C1, C4, in addition to the ventral rootlets and dorsal rootlets. But these midline rootlets ascends up, enter the foramen magnum, running inside the skull, uniting with the cranial root of the accessory nerve that originates from the medulla oblongata, and both nerves exit out of the skull via the jugular foramen. The spinal accessory supply the sternomastoid muscle and the trapezius muscle, while the cranial accessory goes to muscles of the pharynx, larynx, and palate. Another exception could be seen in transverse section of the spinal cord. Routinely, we have in a transverse section of the spinal cord H-shaped gray matter formed by right and left limbs connected by gray commissure. H-shaped. The limbs formed by bilateral ventral motor roots or column and bilateral dorsal sensory roots or column or horns. But some regions of the spinal cord or some segments of the spinal cord, if you will have a transverse section in them, you will have, in addition to the ventral motor horn and the dorsal sensory horn, you will find laterally a lateral horn. And this region, that when you will have a section, transverse section, and then you will see a lateral horn, are the following. Number one, the segments from T1 till L1, which means thoracic segments down to the first lumbar segments. And number two, spinal segments, sacral second, sacral third, and sacral fourth. As we said, all the gray-shaped, the S-shaped gray matter contains neurons, and the white matter contains myelinated nerves. So, because this lateral horn seen in segments T1 down to L1 and spinal segments S2, 3, 4, this lateral horn must contain neurons, so we must know the function of these neurons. You know, we said that the ventral horn is a motor in function, containing neurons that is related to motor function. The dorsal horn contains sensory neurons. So what is the function of the lateral horn? The function of the lateral horn is to give autonomic function, that is containing neurons of origin to the sympathetic sympathetic function and segment from T1 to L1. Here, the lateral horn have neurons related to sympathetic outlet, while the lateral horn at second sacral, third sacral, fourth sacral, S2, 3, 4, containing neurons that are related to the outlet of the parasympathetic system, This outlet of the parasympathetic system is sometimes called nervi urgentis because it is related to a reduction of the pain. Someone may think that when we are saying spinal segment, cervical and thoracic, lumbar and sacral, someone may think that each segment lies at the level of the vertebra of the same number, of the corresponding number. But this is not the situation. You know, the lower end of the spinal cord, as we said before a while, is at the level of the lower border of L1. So actually this subject leads us to the developmental anatomy of the spinal cord. In embryo or in fetus actually, till the 3rd month of pregnancy, the spinal cord fills all the vertebral canal, and thus fetus, each segment is related on the size to the, each segment lies opposite to the vertebra of the same number. For example, this is L3 vertebra, and so this is L3 segment of the spinal cord. This is an embryo or in fetus till the 3rd month of development. And in that situation, the spinal nerve, for example, this one, from the 3rd L3 segment of the spinal cord, exit the spinal nerve from the intervertebral foramen below L3. So the spinal nerve will only pass from the L3 segment, for example, below L3 vertebra via this intervertebral foramen and get out. But as development proceeds, the vertebral column elongates much rapid than the spinal cord, and therefore at birth the spinal cord will be at the level of the lower border of L3, and at adulthood it will ascend further to be at the level of L1, and in both conditions, at birth and adulthood, the spinal nerves and the spinal segments are not corresponding to the level of the vertebra of the same number. And that's why, due to this descent of the level of the vertebrae and ascend of the level of the segments of the spinal cord, you will find that the upper segments of the spinal cord are nearly near the vertebra of the same number. And so you can say that the spinal nerves of the upper segments pass laterally to reach the intervertebral foramina of the same number. And so somewhat these spinal nerves run horizontally from the segment of a spinal cord, horizontally to exit from the intervertebral foramina. But if you will go down in the segments of the spinal cord, the spinal nerves must descend a little to reach the corresponding level of their intervertebral foramen and thus exit out. For example, this is the T7 nerve. T7 nerve originated from T7 segment of a spinal cord. When during the fetal life, T7 was at the segment was at the level of T7 vertebra, and so T7 nerve passed horizontally to exit out of the intervertebral foramina. But at adulthood, T7 segment is higher than T7 vertebra, and so the spinal nerve must descend down to reach the corresponding intervertebral foramina and get out. And the obliquity, such a descent or obliquity of the spinal nerve, are more sharply increasing as you are going downward, till reaching the lower segments of the spinal cord. Here you will find that the spinal nerve must run steeply or very, very obliquely downward to reach the corresponding number of intervertebral foramina and thus this is the factor behind formation of the coda equina below the level of L1 vertebra, in which here below the level of L1 vertebra you don't have spinal cord in the vertebral canal, but you can see that all the nerves running downward obliquely to reach the corresponding intervertebral foramina, and thus this collection become in the shape of coda equina, which is the tail force. Generally, the obliquity or the descent of the spinal nerves from each segment of the spinal cord have a general numbering or description. We can say roughly that in the cervical segment, the difference between the segment of the spinal cord and the vertebra of the same number is a difference of one level, which means that in the cervical region, the T3 cervical nerve or segment of the spinal cord is lying at T2 vertebra. It is higher. And in the thoracic region, the level is 2 difference. For example, T4 segment of thoracic segments of the spinal cord lies at the level of T2 vertebra, and in the lower thoracic, this is in the upper thoracic, in the lower thoracic the difference is 3. For example, T10 lies at the level of T10 level segments of spinal cord lie at the level of the T7 vertebra, but this is a rough estimation and it is not so accurate. The spinal cord is sometimes described as a cylindrical structure running inside the vertebral canal. But actually, the cylindrical spinal cord running inside the vertebral canal is not of uniform thickness. Some regions of the spinal cord are thicker or larger than other regions. And if you will consider the transverse section of the spinal cord, you may expect that the change in the thickness of the spinal cord must be due to a difference either in the H-shaped gray matter or in the white matter surrounding the H-shaped gray matter, or maybe it is because of both of them, logically. Actually, let's start with the cervical region that shows thicker cord, or which is called cervical enlargement. This is the cervical enlargement. Here, in the cervical segment of the spinal cord, we have the roots that forms the brachial plexus, which are the fifth cervical, C7, 5, 6, 8, and T1. And so at these segments, C5, 6, 7, 8, and T1, the ventral horn, which is the motor horn, is very significant in function, because here the neurons in the ventral horn of a gray matter forms the brachial plexus, so we have a big ventral horn. And so this big ventral horn leads to an enlargement in the cervical region at these segments. And similar enlargement could be seen in the lumbar region, because in the lumbar region, here also in lumbar region from L2, 3, 4, 5, and also at the level of S1, 2, 3, here the lumbosacral plexus occur. or originates from these segments of the spinal cord, and thus also the ventral horn of H-shaped gray matter is of massive function, contain many neurons because these segments L1, 2, 3, 4, F5, S1, 2, 3 give rise to lumbosacral plexus that supply the lower limb. So large uh, ventral horn in these segments leads to a large spinal cord which is called lumbar enlargement in this region. But if you compare the lumbar enlargement with the cervical enlargement, you can see that the cervical enlargement is thicker than the lumbar enlargement, although both of them having large ventral motor horn. Such a difference, the much larger cervical enlargement compared to lumbar enlargement, is due to much white matter in the cervical enlargement compared to white matter in the lumbar enlargement. And the reason behind that is that the white matter contains myelinated nerves, and these myelinated nerves either descending down from the brain down to the limbs or trunk, which are descending motor nerve fibers, or the white matter contain ascending nerves, which are sensory nerves going up to the brain. And so the cervical enlargement contains much white matter because here you have many descending motor nerves in the white matter that are still not leaving because they are not reaching down to their destination. You have here all the descending nerves that in the cervical region they will be in the white matter, and when we will reach the upper limb it will lead to the upper limb, reaching the thorax, lead to the thorax, and so and so. So as you are going downward, the white matter will be less because descending motor neurons descending from the brain are leaving at each subsequent lower segment, and thus the white matter will be less. And similarly, the ascending nerve fibers going from the limbs and the trunk will be collected as you are going above. So in the cervical region you will find much of the sensory ascending nerves going up into the brain, so the white matter here is much thicker. Some scientists made many studies in order to know the functional role of each part of the gray matter, of the H-shaped gray matter. And accordingly, due to these studies, the H-shaped gray matter had been divided into many groups. Initially, the general arrangements done in the earlier studies divides the H-shaped gray matter as a ventral horn, which is motor, and dorsal horn, which is sensory, and intermediate horn in between. But further investigation by more advanced histological techniques were able to divide these parts, the dorsal horn, the ventral horn, and the intermediate region into a smaller regions. Each of these have a similar functional and histological criteria. So they are grouping the ventral horn into a lateral group and a medial group, and they are dividing the dorsal horn into post-marginal nucleus, substantial gelatinose, dorsal nucleus of Clark, and the intermediate region is divided into and intermediomedial and intermediolateral nuclei. Other studies shows what's called somatotopia. They shows that the ventral motor horn of spinal cord shows neurons that are concerned with motor function of the hand in the lateral part of the ventral motor horn. And as you are going medially, you will find that the most lateral is for the hand, going medial, this is the arm, and going more medial, this is the trunk or shoulder region, or you will have a similar arrangement in the, this is for example in the region of brachial plexus, the hand, arm, and shoulder, but in the lumbosacral plexus you will find the foot and thigh and trunk or head region as you are going from lateral to medial. And also they found that the dorsal motor gray horn ventrally responsible for supplying extensor muscles by motor activity, while dorsally here the neurons supply the flexor muscles. And such arrangement is called somatotopia or somatotopical arrangement of neurons. Another scientist, which is called Rixed, have a laminar arrangement also according to function and histology. And these lamina, which are called Rixed-lamina, are lamina 1, 2, 3, 4, and so on. And you can find these lamina are similar to the nuclei which are described here. The same, these nuclei are arranged into a lamina, as you can see. For example, the post-marginal nucleus is lamina 1. Then substantia gelatinosa is lamina 2. Nucleus propria is lamina 3. Those are nucleus and so on. So these are the same arrangement. I don't want you to remember all of these. It's enough to know that the histology and function of the gray matter of spinal cord allows researchers to divide them into nuclei and laminae, and allows them to localize somatotopia. Probably somatotopia is very important, more than the division of the lamina and nuclei. For example, if you will have pressure, for example, for any reason, let's say tumor, on the lateral side of the ventral horn or lateral side of the spinal cord in the region of the cervical enlargement, you will supposedly having paralysis in the hand before the thigh or before the arm, because the pressure on the lateral side will first affect the hand. And for example, if you have a pressure due to a tumor from the anterior aspect, so you will have probably damage to the extensor muscles before the flexor muscles. So somatotopia is important to be remembered, but the regional classification of nuclei and of laminae are only for general knowledge. And this is a summary to the arrangement with comparison to the lamina, the Rixed lamina, to the nuclei of the gray matter of spinal cord. It is shown in the figure and also described with the text. Regarding the coverings of the spinal cord, in the earlier part of this lecture, we had said that the pia mater covers the outer surface of the spinal cord. And of course, pia mater is one of the three layers of the meninges covering the spinal cord. So outside to the pia mater covering the spinal cord is the arachnoid matter. And you know that the space between the pia and arachnoid is called subarachnoid space, which is filled with cerebrospinal fluid, with CSF. That is called the subarachnoid space filled with CSF. And to outside of the pia mater, this is the dura mater. And the space between the arachnoid and the dura is the subdural space, which is a potential space. You can see that the pia that is closely adherent to the cord, to the tissue of the spinal cord, shows a lateral extension, just like a tooth-like extension of the pia. These extensions passes laterally from the lateral aspect of the cord into the subarachnoid space and are attached to the sides of the dura. These extensions are called denticulate ligament or ligamentum denticulatum. And actually, this is a very beautiful picture for the ligamentum denticulatum, tooth-like processes of pia mater extending from the spinal cord laterally into the subarachnoid space. And these are, of course, tooth-like processes on both sides, so they are representing 21 pair tooth-like pia mater extensions on the sides, and they are attached to the dura. These tooth-like processes add stability to the position of the spinal cord inside the vertebral canal. And also in the earlier part of the lecture, we had said that the pia mater covering the spinal cord extend in a form of thread-like extension below the lower end of spinal cord at L1. This thread-like extension, we call it phylum terminale. So below the level of the lower level of the spinal cord, which is at the lower border of L1, what are the extensions of the dura and arachnoid and pia? The dura of arachnoid matter extends beyond L1, beyond the lower end of spinal cord, till reaching the second vertebra. So you have subdural space and subarachnoid space between L1 and S2 vertebra. The subarachnoid space here supposedly contains CSF, and also here the subarachnoid space, the CSF in this region contains the coda equina. This region of subarachnoid space between the lower end of spinal cord at L1 and the lower end of the arachnoid and the dura at S2, which contains CSF and coda equina, is called lumbar cisterna, because it is a very large subarachnoid space. And in this region, you can introduce a needle in between the vertebrae below L1, in this large subarachnoid space, which is the lumbar cisterna, to get aspiration of some of the CSF. For example, to use this cerebrospinal fluid, the CSF, for clinical examination to diagnose a clinical condition. Or you may put a needle in this lumbar cisterna, in the big subarachnoid space below L1 till S2, to inject a drug that is anesthetic drug, and thus you will produce anesthesia of all the spinal nerves running in the lumbar cisterna, which are the spinal nerves forming the coda equina. The question is that the dura and arachnoid extends down to S2. And you know that deep to the arachnoid you have pia that formed phylum terminale. And phylum terminale land with the coda equina nerves, the spinal nerves forming the coda equina. And surprisingly that the pyometer forming the phylum terminale extends beyond the S2, which is the lower end of the dura and arachnoid. The phylum terminale, the pia forming phylum terminale, extends more inferior than the S2 vertebra to be attached to the first coccygeal vertebra. This is a figure, or these are figures for having a needle in between the vertebrae, inside the intervertebral disc, into the large subarachnoid space below L1. This region, the large subarachnoid space below L1, is the lumbar cisterna. It is filled with CSF and containing the lower spinal nerves forming coda equina and phylum terminale. This is the procedure of putting a needle either to get the fluid for a clinical examination to diagnose a disease, or maybe to inject the drug and thus producing caudal anesthesia that may allow a surgical operation in the abdomen and in the lower part of the trunk while the patient is awake. When you will introduce this anesthesia, you will have anesthesia in the lower trunk, and you can have an abdominal operation, and the patient is conscious because all the lower segments of the spinal cord are now anesthetized by this drug injected. You can imagine here that the needle introduced could not pass into the nerve because the nerves of the coda equina are floating in the CSF, and if the needle is near to the nerve will be deviated away from the passage of the needle. I think this information, in consideration to gross anatomy of the spinal cord, are very important, and this is a very sufficient or much knowledge about the spinal cord, and we will stop here, but in the next lecture we will talk also about the spinal cord, but we will talk about the white matter of the spinal cord. Before a while we said that the spinal cord, the white matter of the spinal cord, contains either motor fibers descending from the brain down in the white matter, or sensory fiber ascending from below up, carrying sensation to the brain. And so these ascending and descending nerve fiber, the ascending are sensory, the descending are motor, are needed to be described in details, and this is what will be discussed in the next lecture. Thank you very much.